right, story time. So picture this. I'm in my NP clinicals, still very much a student, still secretly Googling normal respiratory rate on my phone in the bathroom because I can never remember if it's 12 to 20 or 16 to 20. It's 12 to 20, by the way. You're welcome. And this woman walks in for what's supposed to be a routine diabetes follow-up. Should be simple, right? Check her A1C, talk about her blood sugars, adjust her metformin, send her on her way. Easy day. Except the second she sits down, my brain goes, nope. Something's wrong here. Now, I don't have a reason yet. Her vitals are perfect. Blood pressure 128/82. Heart rate 76. Oxygen sat 98%. She's not clutching her chest. She's not gasping for air. Everything looks fine, but she's pale. She's breathing just a little harder than she should be. And she keeps rubbing her jaw, just absent-mindedly touching the left side of her jaw while we're talking. And I'm standing there thinking, okay, Jennawè, you're a student. You've seen 30 patients in your entire NP program. You don't have clinical intuition yet. Calm down. You're probably overthinking this. But my gut is screaming, full volume, all caps, something is wrong, screaming. So I do what any anxious NP student does when they think they're seeing something but don't want to look stupid. I whisper to my preceptor, very quietly, like I'm confessing a crime. I know this is going to sound weird, but something feels off about this patient, maybe. And bless my preceptor, he didn't roll his eyes or give me that poor little tink-tink look. He just looked at the patient, then looked at me, then nodded. He asked the patient, before we talk about your blood sugars, tell me, how are you feeling today? Really feeling? The patient said, oh, I'm fine, just a little tired. Any discomfort anywhere? She paused, then said, well, my jaw's been bothering me a little, but I think I slept on it wrong. Jaw pain. Fatigue, pale, subtly short of breath. My preceptor's face changed. He looked at me, then back at the patient and said, I'm going to do an EKG, just to be safe. The patient looked confused. For my jaw? Just humor me. Long story short, ST elevation in leads 2, 3, and a VF. She was having an inferior MI. Classic atypical presentation. We called 911. She went to the ED, got whisked to the cath lab, got a stent placed. One of her coronary arteries was 90% blocked. She went home 3 days later doing great. After the ambulance left, my preceptor turned to me and said, how did you know? And I said, I have absolutely no idea. He smiled. That's pattern recognition. Your brain saw something before you were consciously aware you were seeing it. And that moment, that's when I realized you don't need 10 years of experience to start developing clinical intuition. Your brain is already building it. You just have to understand how it works and train it deliberately. So today we're breaking down the neuroscience of pattern recognition, how your brain learns to see things you're not consciously aware of, how expert clinicians develop that gut feeling that students think is magic. Spoiler alert, it's not magic, it's neuroscience, and you can train it. Even as a student who still Googles normal vital signs. Welcome to the Think Like a Provider podcast. I'm Jennawè, nurse practitioner and clinical educator, also the creator of Think Like a Provider, the clinical reasoning system that teaches you to master body systems through pathophysiology and evidence-based frameworks. Here we don't memorize, we understand. Each episode, we break down clinical reasoning system by system so you walk away thinking and acting like the provider you are meant to be. All right, so here's what we're diving into today. This is our monthly neuroscience deep dive, where we look at how your brain actually learns clinical reasoning. Not just what to learn, but how learning happens inside that beautiful, exhausted, over-caffeinated brain of yours. And today's topic is one of the most misunderstood concepts in nursing education, pattern recognition, because students hear pattern recognition and they think it means memorizing a bunch of disease presentations and matching them to patients, like you're playing some twisted medical version of memory. But that's not what pattern recognition is. That's pattern matching, and there's a massive difference. Real pattern recognition, the kind that expert clinicians use, the kind that saves lives, happens at a level your conscious brain isn't even aware of. It's happening right now, actually, while you're listening to this. Your brain is pattern matching my voice, my cadence, my word choices against every other teacher you've ever had. It's deciding, do I trust this person? Does she know what she's talking about? Should I keep listening or just go doom scroll on TikTok? Please keep listening. I promise this is going somewhere. And once you understand how pattern recognition actually works in your brain, you can train it deliberately, strategically, even as a student. So let's break down the neuroscience. The problem: students think pattern recognition is memorization. Here's what most students think pattern recognition means. You memorize what diseases look like. You see a patient. You match what you're seeing to what you memorized. Boom, diagnosis. You're basically Dr. House now, right? Wrong. So for example, you memorize that heart attack's present with chest pain, shortness of breath, diaphoresis, nausea, and left arm pain radiating down like someone's playing the world's worst game of Operation on you. Then you see a patient with those exact symptoms and you think, oh, this matches my mental picture of an MI. This is a heart attack. And that can work when the patient presents with the classic textbook presentation, when they're a 65-year-old man with crushing substernal chest pain, and they're literally pointing to their chest like, this, right here, this is the problem. But here's the issue. Most patients didn't read the textbook. They didn't get the memo about how they're supposed to present. The woman I saw in my NP clinicals, no chest pain, no left arm pain, no diaphoresis, just jaw discomfort, fatigue, and subtle shortness of breath. If you looked her up in the textbook, she'd be filed under "that's weird, not classic MI." If I had been trying to pattern match her symptoms to my memorized list of MI symptoms, I would have missed it completely. My brain would have said, nope, doesn't match, must be something else. Probably just slept wrong. Moving on. But my brain recognized the pattern anyway. Even though it didn't match the textbook, even though I couldn't consciously articulate what was wrong yet. So, how did that happen? Here's where the neuroscience comes in. And don't worry, I'm not about to make you memorize the parts of the brain. You're welcome. Two types of memory: explicit versus implicit. Your brain has two fundamentally different memory systems, and understanding the difference is the key to understanding pattern recognition. Think of it like this. Your brain has a filing cabinet and a hard drive. The filing cabinet is slow, organized, and you have to consciously look stuff up. The hard drive is fast, automatic, and runs in the background without you thinking about it. System 1, explicit memory, the filing cabinet. But this is the memory you're aware of. The stuff you consciously study and recall. When you sit down with your overpriced nursing textbook, you know, the one that weighs approximately 47 pounds and costs more than your car payment. And you memorize signs and symptoms of heart failure, shortness of breath, edema, fatigue, weight gain. That's explicit memory. When you're in an exam and you're thinking, okay, what are the risk factors for stroke? Let me recall. Hypertension, diabetes, atrial fibrillation. That's explicit memory. This memory lives in your hippocampus, the part of your brain responsible for conscious recall. And here's the thing, explicit memory is slow. It requires effort. It's deliberate. You have to actively think about it to access it. It's like when someone asks you, what's the normal potassium range? And your brain has to rifle through the filing cabinet like, hold on, I know this, I learned this. Where did I put that? 3.5 to 5.0, got it. System 2, implicit memory, the hard drive. This is the memory you're not consciously aware of. It's automatic. It happens without you thinking about it. When you walk into a patient's room and something just feels off, that's implicit memory. When you hear a heart sound and you immediately know it's abnormal, even though you can't explain why, that's implicit memory. When you look at a patient and your gut says, this person is sick, even though the vitals are stable and they're smiling and telling you they're fine, that's implicit memory. This memory lives in different parts of your brain, your basal ganglia, your cerebellum, your amygdala, parts of your brain that work automatically, below conscious awareness. They're the autopilot system. And here's the critical difference. Implicit memory is fast. It's effortless. It's intuitive. You don't have to think about it. It just happens. Like when you're driving and you automatically brake when the car in front of you slows down, you're not consciously thinking, okay, car slowing. I should apply pressure to the brake pedal now. Your brain just does it. Now, here's what students don't understand. And this is the part that changes everything. Real clinical pattern recognition is implicit memory, not explicit memory. When an expert nurse walks into a room and immediately knows something's wrong, they're not consciously running through a checklist. They're not pulling up their memorized list of signs of deterioration from the filing cabinet. Their hard drive is running in the background, pattern matching this patient against hundreds or thousands of previous patients. And it's sending up a red flag. Hey, this looks like that patient who crashed 2 hours later. Pay attention. And that recognition happens in milliseconds, faster than conscious thought. That's why experienced nurses will say things like, I just knew, or my gut told me. They're not being mystical or vague. They're describing implicit memory doing exactly what it's designed to do. How your brain builds patterns, the neuroscience. All right, so let's talk about how your brain actually builds these automatic pattern recognition skills. Because you can't just download clinical intuition like a software update. Though honestly, if Apple could make an app for that, nursing students would pay embarrassing amounts of money for it. Stage 1. Explicit learning, conscious study. When you're a student, you start by explicitly learning things. You read, sepsis presents with fever, tachycardia, hypotension, altered mental status. You highlight it, probably in 3 different colors because you bought that 47 pack of highlighters on Amazon and you're gonna use them, dang it. You memorize it, you repeat it, you make flashcards, you quiz yourself, you study it for your exam. This information gets encoded in your hippocampus as explicit memory. At this stage, when you see a patient who might be septic, you have to consciously think through it. You're literally running the checklist in your head. Okay, let me check. Do they have a fever? Yes. Tachycardia? Yes. Hypotension? Not yet, but blood pressure is trending down. Altered mental status? Yeah, they're a little confused. Is this sepsis? Let me think. Yeah, probably. I should tell someone. It's slow, it's effortful, and honestly, it's kind of exhausting. Stage 2, repeated exposure, building the database. Now you start seeing patients, lots of patients, and you see a patient with sepsis, then another one, then another one, and another one, because apparently sepsis is everywhere, and nobody taught these people about hand hygiene. And here's what happens in your brain that most students don't realize. Each time you see a septic patient, your brain doesn't just store it as a boring list of symptoms. It stores the entire gestalt, the whole picture, the vibe, if you will, the way they look, the way they sound, the subtle changes in their skin tone, the quality of their breathing, the flatness in their voice, the way they're just off. All of that gets encoded together as one integrated pattern. And each time you see another septic patient, your brain strengthens that pattern. It refines it. It adds nuance. Patient A had sepsis from pneumonia, looked like this. Patient B had sepsis from a UTI, looked like this. Patient C had sepsis from an abdominal source, looked like this. Your brain starts to recognize, okay, these are all sepsis, but they look slightly different depending on where the infection is. Interesting. Filing that away for later. And your database grows. Stage 3, pattern consolidation, moving from explicit to implicit. Here's where it gets really cool. After you've seen enough examples, dozens, hundreds, your brain starts to move that information from explicit memory to implicit memory. It's called consolidation, and it happens mostly while you sleep, which is why pulling all-nighters before clinical is actively sabotaging your learning, but that's a different episode. The pattern gets transferred from your hippocampus, where you have to consciously recall it, to your basal ganglia and cerebellum, where it becomes automatic. It's like learning to drive. At first, you're consciously thinking, check mirrors, signal, look over shoulder, merge. Every step is deliberate, but after a few months, you're merging onto the highway while singing along to Taylor Swift and thinking about what you're going to eat for lunch. It's automatic. Your brain moved that skill from explicit to implicit. Same thing happens with clinical pattern recognition. Now, when you walk into a room and see a patient who's septic, you don't have to think through the checklist anymore. You just know. Your brain recognizes the pattern instantly, automatically, without conscious thought. And this happens in milliseconds, faster than you can articulate what you're seeing. That's what people call clinical intuition, but it's not magic. It's not a gift. It's just your brain recognizing a pattern it's seen before and doing it automatically because you've trained it. Pretty cool, right? Why memorization doesn't build pattern recognition. All right, so here's where students get stuck. And honestly, this is where I got stuck too. So no judgment. They think if they just memorize enough content, they'll develop pattern recognition. They're out here making 47 Quizlet decks, highlighting entire textbooks. Seriously, if your whole page is yellow, you've highlighted nothing. Doing thousands of practice questions and thinking, if I just know more, I'll get better at this. But memorization only builds explicit memory. It doesn't build implicit memory. And you need implicit memory for real pattern recognition. Let me show you why with an example. Memorization. Example how most students think. You memorize, MI presents with chest pain, shortness of breath, diaphoresis, nausea. Then you see a patient with jaw pain, fatigue, and subtle dyspnea. Your brain searches your explicit memory, running through the checklist. Does this match my list for MI, chest pain? No. Shortness of breath, sort of, but it's subtle. Diaphoresis, no. Nausea, no. Conclusion. This doesn't match. Probably not an MI. Maybe it's anxiety, TMJ. I don't know, but it's not cardiac. You miss it. The patient codes 3 hours later. You feel terrible. Your preceptor gives you that look. You question all your life choices. Pattern recognition. Example, how expert clinicians think. You've seen MIS during your RN years, some with classic chest pain, some with jaw pain, some with back pain, some who just felt off and couldn't really explain it. Your brain has stored all of those experiences as integrated patterns, not lists, pictures, vibes, full experiences. Now, as an NP student, you see a patient with jaw pain, fatigue, and subtle dyspnea. Your brain instantly pattern matches, not to a memorized checklist, but to one of those previous real-world experiences. This feels like that patient I had in the ICU 2 years ago. Middle-aged woman, inferior MI, presented with jaw pain and fatigue. No classic chest pain. We almost missed it. Your gut says, something's wrong. This could be cardiac. I should say something. You speak up. Your preceptor investigates. You catch it early. The patient gets treatment. Everyone goes home happy. See the difference? Memorization gives you a checklist. Pattern recognition gives you a database of real-world, messy, atypical presentations. And the database wins every single time. Because here's the truth. Patients don't read the textbook. They don't present the way they're supposed to. They present the way they present. And if you're only equipped with a memorized list, you're gonna miss a lot of stuff. The role of experience. Why you need 10,000 hours. Or do you? All right, so you've probably heard about the 10,000 hour rule. Malcolm Gladwell made it famous. The idea that it takes 10,000 hours of practice to become an expert at anything. And there's some truth to that. Research shows that expert clinicians have seen thousands of cases. All that exposure builds robust pattern recognition. But here's what students hear when you say 10,000 hours. Oh, great. So at 40 hours a week, that's, let me pull out my calculator, 250 weeks, which is almost 5 years. Cool, I guess. So I won't be a good nurse for half a decade? Guess I'll just accept being terrible until then. Thanks, Malcolm Gladwell. And that's not true. That's not how this works. Because the quality of experience matters way more than the quantity. Let me explain. Passive experience versus deliberate practice. You could see 1,000 patients and not learn much if you're just going through the motions, just checking boxes, just trying to survive your shift. Or you could see 100 patients and learn a ton if you're actively reflecting on each one, if you're deliberately building your pattern database. Here's the difference. Passive experience, what most people do. See a patient with sepsis, treat them according to protocol, chart your interventions, move on to the next patient. Your brain files it away in the background, but doesn't deeply encode it. Repeat 47 times that shift. Go home exhausted and forget most of it by tomorrow. Deliberate practice, what builds expertise faster. See a patient with sepsis. Actively notice, what did this patient look like? What were the early signs I noticed? What did I almost miss? How was this patient different from the last septic patient I saw last week? Mentally compare and contrast. Patient A had sepsis from pneumonia and looked like X. This patient has sepsis from a UTI and looks like Y. Interesting, same process, different presentation. Your brain deeply encodes the pattern, strengthens the neural pathways, builds the implicit memory faster. 5 minutes of reflection after the shift to write it down. See the difference? Same patient, same amount of time, but one approach builds pattern recognition way faster than the other. So you don't need 10,000 hours if you're deliberately practicing. You need smart exposure, intentional exposure, reflective exposure. Quality beats quantity every time. And honestly, some of the best clinicians I know have been in practice for 2 to 3 years, but they practice deliberately. They reflect, they compare, they learn from every patient. And some clinicians have been practicing for 20 years, and they're still thinking like novices because they've just been passively going through the motions. Don't be that person, be deliberate. How to train pattern recognition, practical strategies. All right, so here's the big question. How do you actually train pattern recognition? Because if it's implicit memory and it happens automatically, can you even control it? Yes, you can. Here's how. Strategy 1, seek varied exposure. Your brain builds patterns through repeated exposure to similar but different examples. So, if you want to recognize sepsis, you need to see sepsis from different sources, in different age groups with different presentations. The more varied your exposure, the more robust your pattern becomes. In school/clinicals, don't just stick to one unit. Rotate through different specialties. Don't just see easy patients. Seek out the complex ones. Don't avoid the patients that scare you. Those are the ones that build your database. Strategy 2, actively compare and contrast. After you see a patient, don't just move on. Stop and compare. How was this patient's presentation similar to others I've seen with the same condition? How was it different? This forces your brain to refine the pattern, to notice nuances, to build a more detailed implicit memory. For example, you see a patient with heart failure who's young and has no edema, just shortness of breath. Don't just think, that's weird. Stop and reflect. Most heart failure patients I've seen have been older and had peripheral edema. This patient is different. Why? What does that tell me about the underlying pathophysiology? That reflection strengthens the pattern, makes it more flexible, more nuanced. Strategy 3, use spaced retrieval. Your brain consolidates patterns better when you revisit them over time. So after you see a patient with a particular condition, deliberately bring that case back to mind a few days later, then a week later, then a month later. This is called spaced retrieval, and it's one of the most powerful learning techniques in neuroscience. How to do it. Keep a clinical journal. Write down interesting cases. Review your journal weekly. Reread old cases. Ask yourself, if I saw this patient today, what would I notice? What would I do differently? That repeated retrieval strengthens the implicit memory, moves it from short-term to long-term storage. Strategy 4, learn from near misses. Your brain learns fastest from mistakes and near misses. So when you almost miss something or when you do miss something, don't beat yourself up and move on. Stop, reflect, Analyze. What did I miss? What pattern should I have recognized? What will I look for next time? That reflection creates a strong emotional tag on the memory, and your brain prioritizes emotionally tagged memories. It consolidates them faster. Example, you see a patient who seems fine. You chart stable, no acute distress. 2 hours later, they code. Don't just feel bad. Reflect. What did I miss? Looking back, were there early signs I didn't recognize? What will I look for next time to catch it earlier? That near miss becomes one of the strongest patterns in your database because your brain is wired to learn from threats. Strategy 5. Study expert thinking. Out loud. One of the fastest ways to build pattern recognition is to watch an expert clinician think out loud. Because experts are accessing implicit memory you don't have yet, and when they verbalize their thought process, they're making the invisible visible. How to do it? Shadow experienced nurses or providers. But don't just watch them work. Ask them to talk through their thinking. What did you notice when you walked in the room? What made you concerned about that patient? What are you looking for right now? Their answers give you a shortcut. They're telling you what patterns to look for, patterns you haven't built yet through your own experience. The science of gut feelings. All right, let's talk about something students find really frustrating: gut feelings. You hear experienced nurses say things like, I just had a feeling something was wrong. My gut told me to check on that patient. I can't explain it, but I knew they were about to crash. And students think, great, so I just have to wait until I magically develop intuition? How is that helpful? But here's the thing, gut feelings aren't magic. They're pattern recognition, happening at a subconscious level. Let me explain the neuroscience. What's actually happening in your brain? When you walk into a patient's room, your brain is processing thousands of data points. Visual, skin color, breathing pattern, body position, facial expression. Auditory, tone of voice, breathing sounds, monitor alarms. Olfactory, smell. Yes, this matters. Septic patients sometimes have a distinct smell. Contextual, time of day, recent vitals, diagnosis, medications. Most of this processing happens below conscious awareness. Your brain is pattern matching all of it against your database of previous experiences. And when your brain recognizes a pattern that's associated with danger, this looks like patient number 47 who coded 2 hours later. It sends an alarm signal. That alarm signal feels like a gut feeling. It's your brain saying, I don't know exactly what's wrong yet, but something about this situation matches a pattern associated with a bad outcome. Pay attention. Why students don't have gut feelings yet? Because you don't have the database yet. Your brain can only pattern match against experiences you've had. If you've only seen 10 patients, your database is small. Your brain doesn't have enough patterns to trigger that alarm signal. But as you see more patients and as you deliberately build your pattern database, those gut feelings will start to happen. And when they do, trust them, because they're not random. They're your brain recognizing something your conscious mind hasn't articulated yet. Novice versus expert pattern, recognition, and what changes. Let me show you what the progression from novice to expert actually looks like in your brain. Novice, student/new grad, relies primarily on explicit memory, consciously thinks through checklists, sees individual symptoms, not patterns, doesn't yet have gut feelings, needs time to process information, follows protocols rigidly. Advanced beginner, 1 to 2 years experience, starting to build implicit memory, recognizes some common patterns automatically, still relies on conscious thought for complex cases, starting to get occasional gut feelings, but doesn't trust them yet, faster processing than novice, but still deliberate, competent, 2 to 3 years experience, strong implicit memory for common presentations, automatic pattern recognition for routine cases, gut feelings are more frequent and more accurate, can handle multiple patients without cognitive overload, knows when to slow down and think deliberately, proficient 3 to 5 years experience, extensive implicit memory database. Pattern recognition is primary mode of thinking. Gut feelings are reliable guides. sees the whole clinical picture, not just parts, can anticipate what's going to happen next. Expert, 5+ years with deliberate practice. Massive implicit memory database. Instantaneous pattern recognition. Gut feelings are highly accurate. Sees patterns others miss. Can function at high level even under stress. Knows exactly when to trust intuition and when to slow down and analyze. Now, here's what's important. This progression isn't just about time, it's about quality of experience. You can spend 5 years as a nurse and still think like a novice if you're not deliberately building your pattern recognition, or you can accelerate the process by practicing deliberately. Common mistakes students make. Before we wrap up, let me tell you the 3 biggest mistakes I see students make when trying to develop pattern recognition. Mistake number 1, confusing pattern. Matching with pattern recognition. Students try to memorize typical presentations and then match patients to those presentations. But real pattern recognition is more flexible than that. It recognizes atypical presentations. It sees the pattern even when it doesn't match the textbook. How to fix it? Stop trying to memorize what X looks like. Instead, learn the underlying mechanisms. Understand why symptoms happen. Then you can recognize the disease, even when the presentation is unusual. Mistake number 2, not reflecting on experience. Students see lots of patients, but don't take time to reflect on what they saw. They're so focused on getting through the day that they don't pause and think, what did I learn from that patient? But reflection is what consolidates the pattern. Without it, the experience doesn't stick. How to fix it? After every shift, or at least weekly, spend 10 minutes writing down, what patients did I see? What surprised me? What did I learn? What would I do differently next time? That reflection turns experience into learning. Mistake number 3, not trusting early gut feelings. When students start to develop gut feelings, they dismiss them. I'm just a student, I'm probably wrong. I shouldn't bother the nurse with this. And they ignore the alarm signal their brain is sending. How to fix it? When you get a gut feeling that something's wrong, even if you can't articulate why, speak up. Say, I can't explain it, but something feels off about this patient. Can we take a closer look? You might be wrong, that's okay, but you also might be right. And learning to trust your gut is part of becoming an expert. All right, here's what I want you to take away from this episode. Pattern recognition isn't magic. It's not some mystical gift that only certain people have. It's not something you're born with or you're not. It's a skill. And like any skill, like learning to drive or cook or play an instrument, it can be trained. Your brain builds patterns through repeated exposure, and the more varied and deliberate that exposure is, the faster you build robust, flexible patterns that work in the real world. But here's the key, and I cannot stress this enough. You can't build pattern recognition through memorization alone. Memorization builds explicit memory, the stuff in your filing cabinet that you have to consciously pull up. Pattern recognition is implicit memory, the stuff on your hard drive that runs automatically in the background. And to build implicit memory, you need real-world experience. You need to see patients, lots of them, in all their messy, atypical, why aren't you presenting like the textbook said you would glory. But you don't just need volume, you need reflection. You need to actively compare and contrast. You need to learn from your near misses and your actual misses. We've all had them. You need to study how expert clinicians think out loud. And over time, faster than you think honestly, your brain will start to recognize patterns automatically. You'll walk into a room and just know something's wrong, even if you can't explain why yet. You'll hear a lung sound and immediately know it's abnormal, even if you can't name it. You'll look at a patient and feel that gut alarm. Pay attention. Something's not right here. And when that happens, trust it, because that's not magic. That's not randomness. That's your brain doing exactly what it's designed to do. Recognize patterns, predict threats, and keep your patients safe. And look, I'm not going to lie to you. You're probably not going to feel like an expert tomorrow, or next week, or even next month. This takes time. It takes exposure. It takes deliberate practice, but you're already building it. Right now, every patient you see, every case you study, every reflection you write, that's building your pattern database. So be patient with yourself. Trust the process. And know that every time you feel like you don't know what you're doing, that's actually your brain learning. That discomfort is growth. And that's exactly why I created Think Like a Nurse and Think Like a Provider. Because I don't just teach you what to know, I teach you how your brain actually learns. I teach you the neuroscience behind clinical reasoning, the mechanisms behind pattern recognition, the deliberate practice strategies that accelerate the development of expertise. Not through more memorization, not through more flashcards, through understanding how your brain works and training it deliberately. You can find the link in the show notes, and if you're looking for community, a place where you can practice deliberate reflection with other students who are serious about becoming expert clinicians, be on the lookout for the Think Like a Provider School community. We break down real cases together. We practice pattern recognition deliberately. We reflect on what we're learning. We build each other up. And we accelerate the process of becoming the kind of clinician who just knows. The link to join the waitlist is in the show notes as well. But for now, here's your homework. And yes, I'm calling it homework. After your next clinical shift, or after you study a case or watch a patient encounter, take 5 minutes and write down, what patient or case did I see? What pattern was I supposed to recognize? What did I notice? And what did I miss? What will I look for next time? 5 minutes. That's it. That's deliberate practice. That's how you build pattern recognition faster than passively seeing patients for 10,000 hours. Because experts aren't born. They're built. One patient, one reflection, one pattern at a time. Thanks for listening. I'll see you next week.